Okay, let's dive deep into proximal humerus fractures today. If you're an orthopedic resident heading towards your exit exams, well, you know these are everywhere, but they're definitely complex.
They really are. Common, but tricky. Getting your head around the anatomy, the classification, all the potential pitfalls like AVN, and then the management, it's a lot.
It can feel overwhelming, for sure. So, this deep dive is all about pulling out the essentials you need, specifically tailored for those exams.
And all the insights we're discussing today, they're based on the OrthoMate Simple Notes. You can find them on the website mokyingren.sg.
Right. Those notes were put together by Dr. Mok Ying Ren. He's a sports surgeon over at National University Hospital in Singapore, and he aced his FRCS back in 2022.
So really current and exam-focused stuff.
Exactly. Our mission here is to unpack those notes, hit the critical anatomy, the classifications everyone uses, predicting AVN, and there's some surprising info there, and then look at how to manage different clinical scenarios based on the evidence.
Sounds good. Let's get into it.
All right, foundational knowledge first. Blood supply to the humeral head. What's the main artery we need to worry about, and why is its location so important?
Well, the key player is the posterior circumflex artery. And it's vital because its path takes it right alongside the axillary nerve.
Ah, right, through the quadrangular space.
Precisely. So in a fracture or, a dislocation, both that artery and the nerve are really vulnerable. They can get stretched, compressed, injured.
Okay, posterior circumflex artery, axillary nerve, quadrangular space. Got it. Essential anatomy. Now, patient comes in, you suspect a proximal humerus fracture. What investigations are you ordering straight away?
You absolutely need your standard set of plain x-rays. That means a good AP view, an axillary view.
Or a Velpo view if they really can't manage the axillary.
Exactly, if abduction is too painful. And you also need a Y-scapular view. Those three give you the different perspectives you need to figure out the fracture pattern, see how displaced things are, and check for any dislocation.
And what about CT scans? When do you pull the trigger on getting a CT?
CT becomes crucial when you're dealing with a lot of comminution, multiple fragments, or if you suspect the joint surface itself is involved.
Right.
And definitely if you're planning surgery, it just gives you that essential 3D map that you just can't get from plain films alone. Helps you really plan your approach.
Makes sense. Now, sometimes on those initial x-rays, the humeral head looks like it's sitting a bit low, almost subluxed. What's causing that?
Yeah, that appearance of pseudo-subluxation, as it's called, it's often a mix of things. The deltoid muscle can kind of shut down, become a tonic.
Muscle guarding.
Right, general muscle inhibition around the injury. Plus, you often get hemarthrosis, blood filling the joint space, which can physically push the head down a bit.
Yeah.
It's important to realize this isn't usually a true dislocation where the head is completely out of the glenoid socket.
Good distinction.
Okay.
So that's the initial assessment. Now, the next big step, especially for communicating about these fractures and for exams, is classification. NIRS system, right?
Correct. NIRS is pretty much the standard language we use. And the whole system hinges on understanding what defines a part.
And this definition is absolutely key, isn't it? What makes a fragment a distinct part, according to NIR?
A fragment counts as a separate part if it's displaced more than 1 centimeter or if it's angulated more than 45 degrees compared to the main bone.
The or is important there. Just need one of those.
Exactly. Displacement or angulation, if either one hits that threshold, it's a part.
So using that definition, run us through the different types in NIRS classification.
Okay, so a one-part fracture is basically non-displaced or minimally displaced. It doesn't meet either the 1 centimeter or 45-degree rule. Then you get two-part fractures.
Which means one fragment is displaced or angulated?
Right. One fracture line creating two pieces, and one of those pieces meets the criteria. This could be at the canatomical neck, the surgical neck, the greater tuberosity, or the lesser tuberosity. A three-part fracture means you have two fracture lines, typically involving the surgical neck and one of the tuberosities, resulting in 3 displaced or angulated parts.
So the head, one tuberosity, and the shaft are separate pieces.
Essentially, yes. And then a 4-part fracture involves fracture lines separating all 4 major segments. The head, both tuberosities, and the shaft are all displaced or angulated according to the definition. 3 fracture lines creating 4 parts.
Understanding that definition of a part and how it builds up is fundamental. Okay, let's shift to a major worry with these injuries. Avascular necrosis, AVN. How do we try and predict the risk?
The notes really emphasize using Hertel's criteria for this. These are specific things you look for on the x-rays to gauge the likelihood of the blood supply to the head being compromised ischemia.
Okay, what are those hotel criteria?
There are three main ones. First, you look at the length of the dorsomedial metaphyseal extension, basically. How much bone extends down medially from the head fragment. If that length is less than 8 millimeters, that's one risk factor.
Less than 8 millimeter. Got it. What's next?
Second is the integrity of the medial hinge. You assess if the shaft fragment has shifted relative to the head fragment by more than 2 millimeters in any direction. If it has, the hinge integrity is considered compromised.
Okay, hinge integrity lost if 2 millimeters shift. And the third?
The third is simply the presence of an anatomical neck fracture pattern itself.
Right. And if a patient has all three of those features, what's the predictive power?
Well, according to Hertel's original work back in 2004, if all three criteria are present, the positive predictive value for ischemia, lack of blood flow at the time of injury, is incredibly high. It's cited at 97%.
Wow, 97% PPV for ischemia sounds almost certain. But, and this is a massive but highlighted in the notes, isn't it? Does ischemia automatically mean the patient will develop clinically significant AVN down the road?
This is probably one of the most critical points to grasp, and it really challenges what many assume. The answer is no. AVN does not always develop, even if the head is initially ischemic.
How do we know that?
The notes reference Hertel again, citing a study by Bastian from 2008. They actually assessed blood flow intraoperatively, sometimes even using Doppler, in patients with these high-risk fractures. And the finding was quite stunning.
What did they find?
They found that 8 out of 10 humeral heads that were confirmed to be ischemic during surgery did not go on to develop symptomatic ADN after 6 years of follow-up.
8 out of 10 didn't collapse despite being ischemic initially. That's huge. So the head can potentially revascularize.
Exactly. It suggests there's significant potential for revascularization, maybe through remaining periosteel attachments or other pathways. It means predicting initial ischemia is not the same as predicting future symptomatic AVN requiring further surgery.
That distinction is absolute gold. It changes how you think about management, especially in younger patients, right?
Absolutely. It justifies trying to save the native head, even when the initial x-rays look worrying based on Hertel's criteria, because collapse isn't inevitable.
Okay, this is a perfect point to transition. Let's take this foundational knowledge and apply it to specific patient scenarios, drawing directly from the management strategies in the OrthoMade Simple notes on mokyingren.sg.
Right. Let's start with a common one. The elderly patient with a really comminuted fracture. Imagine, say, an active 80-year-old lady, high function before her fall, but now she has a badly broken proximal humerus, maybe with some of those AVN risk features we just talked about.
How do you approach that? It feels like a tug of war between factors.
It really is. You weigh the patient factors against the injury factors. Her high function, maybe it's her dominant arm that pushes you towards doing something surgically to restore that function.
But the injury itself.
Exactly. The high degree of comminution, the potential AVN risk, the increased risk of arthritis later, or the tuberosity is just not healing well in older bone, those factors start pointing towards maybe a replacement surgery being more reliable.
But you mentioned non-operative management earlier, too. Is that still on the table here?
It absolutely is. And the notes highlight this, referencing evidence like the Proffer trial, which we should definitely unpack more later. For some elderly patients, especially if their overall health isn't great or functional demands are lower, non-operative management is a very acceptable path, even for displaced fractures.
Okay, but let's say you decide surgery is the way to go for this active elderly lady with the bad fracture. What are the main replacement options you're considering?
The two main players are reverse total shoulder arthroplasty, RTSA, or a hemiarthroplasty, just replacing the ball part, the HA.
And what steers you towards one over the other in this specific scenario?
The big decider is often the tuberosities. For a hemiarthroplasty to work well and give good function, those greater and lesser tuberosities must heal reliably back onto the implant and shaft.
Which is a challenge in elderly, comminuted, possibly osteoporotic bone.
Exactly. Tuberosity healing is notoriously unpredictable in these cases. So because RTSA function is much less dependent on perfect tuberosity healing, the notes suggest, and the evidence supports, leaning towards RTSA.
Is there specific evidence backing that up?
Yeah, the notes mention studies like Austin et al. in JOT 2019. They compared RTSA and Hemi for complex elderly fractures and found RTSA generally led to better range of motion, better clinical scores, and importantly, lower rates of needing further surgery down the line.
So RTSA kind of bypasses the unreliable tuberosity healing issue.
Pretty much. And the notes also mention RTSA is inherently designed to work well, even if the rotator cuff isn't functioning perfectly, which can also be an issue after these injuries.
Makes sense. Okay, let's flip the script. Scenario 2. A young patient, say a healthy 30-year-old guy, also with a complex, comminuted fracture, maybe even one showing those Hertel AVN risk flags. Different approach here.
Totally different mindset. Here, preserving the patient's own humeral head is the absolute priority.
Yeah.
We go back to that Bastion study, finding ischemia doesn't always equal collapse.
So you attempt fixation first.
Yes. The standard approach is to proceed with open reduction and internal fixation, or RAF. You accept the AVN risk, counsel the patient about it, but you try to fix their native bone. Replacement is kept in reserve as a salvage option if things go wrong later, like if AVN does develop, or fixation fails, or severe arthritis sets in.
Okay, for fixation in this young patient, nail or plate, what are the considerations?
Both have their place. Intramedullary nails can be an option, especially for maybe 2-part or less complex 3-part surgical neck fractures. The potential upsides are a smaller incision, maybe earlier weight bearing.
But the downside?
The main concern with nails is the insertion point up top, near the rotator cuff insertion. It can lead to shoulder impingement or rotator cuff tendonitis later on.
And what about nails for really complex, like 4-part fractures?
The evidence there isn't great. The notes cite a meta-analysis from JOT in 2016, which showed significantly worse outcomes using nails for 4-part fractures compared to 2- and 3-part ones. So for the complex comminuted fracture in a young person, especially a 4-part, ORIF with a plate is generally the preferred method.
All right, let's walk through that ORF procedure. What are the key steps and tips from the notes?
Okay, pre-op is crucial counseling. Risks of stiffness, non-union, infection, nerve injury, hardware problems, and that residual AVN risk the patient needs to understand all that.
Then intraoperatively.
Typically beach chair position, standard delta pectoral approach. A really vital early step is to find those tuberosity fragments, the greater and lesser, and pass heavy, non-absorbable sutures through their rotator cuff tendon attachments.
Why so early?
It gives you control. You can use these sutures later to pull the tuberosities back into place and fix them to the plate. Then you work on reducing the main fracture fragments, often holding the reduction temporarily with K-wires.
And you need to assess the bone quality.
Absolutely. Before you commit to the plate, look at the bone stock. If it's really poor, especially medially, you might need to think about adjuncts. Maybe a fibular strut graft placed inside the humerus for structural support, or sometimes even accepting a bit of acute shortening to get better bone-on-bone contact. Medial buttress plating can also be critical to prevent that common varus collapse.
Then comes the plate itself. Any specific technical points?
Yes. Applying the lateral proximal humerus locking plate. The really crucial technical pearl highlighted is getting a solid medial kickstand calcar screw.
The kickstand screw. Explain that again. Why is it so important?
It's a specific screw, usually locking, placed through one of the most inferior and medial holes in the plate, angled upwards into the dense bone of the calcar region of the humeral head. It acts as a direct buttress against varus collapse.
And there's evidence for this.
Strong evidence. Gardner et al. In JOT 2007 showed that having that inferomedial support screw significantly reduced the rates of losing the reduction, the head losing height, and screws loosening over time. It's a key stability element.
Makes sense. Then you tie down those rotator cuff sutures.
Exactly. Once the plate is secure, you tie the sutures you placed earlier down to the plate, helping to pull the tuberosities into their correct anatomical position and compress them.
And post-op care after this ORIF.
Immediate focus is neurovascular checks. Brachial plexus, axillary nerve, musculocutaneous nerve are all nearby. Then early, gentle passive motion is key to prevent stiffness. Usually start with pendular exercises. You'll typically wait for signs of healing on X-ray, often around 6 weeks, before allowing any weight-bearing or more active movement.
Okay, comprehensive. Now, back to the elderly population. Let's say non-operative management is the chosen path. Maybe an elderly lady, poor function beforehand, non-dominant arm. The notes really emphasize the PROFER trial here.
Yes, PROFER is a landmark trial for this exact question. Proximal fracture of the humerus. Evaluation by randomization. It directly compared surgery versus non-surgery for displaced fractures in older adults.
What was the study setup?
It was a big multi-center RCT. Over 250 patients, average age 66, all with displaced 2, 3, or 4-part fractures. They were randomized to either get surgery, which could be fixation or replacement, or non-surgical management, typically a sling followed by physiotherapy.
And the big result, what did they find?
The bottom line was no statistically significant difference between the surgical group and the non-surgical group. This was true for functional outcomes like the Oxford Shoulder Score, quality of life scores like the SF-12, and complication rates.
No difference in function, even out to longer follow-up.
They followed patients out to 2 years and even 5 years, and the lack of difference held up. There was also no difference in the rate of needing further revision surgery between the groups.
That's a pretty powerful finding, suggesting surgery might not be universally better for this group. But like all trials, were there criticisms or limitations to keep in mind?
Definitely. One major point is that patients who the surgeons felt had a clear indication for surgery, often the very displaced or unstable ones, were actually excluded from randomization. That was nearly 90 patients. So the trial might not apply to the most severe end of the spectrum.
Okay, selection bias potentially.
Also, there was huge variability in surgical technique, with 66 different surgeons involved. And interestingly, about 13% of patients who were randomized to surgery ended up not having it for various reasons. That crossover could dilute any potential surgical benefit.
Important caveats when you're applying proffer to your individual patient. Okay, one last specific scenario. The fracture dislocation. These sound particularly nasty to manage, especially acutely in the ED.
They are definitely a step up in complexity and urgency. The notes mention Wei et al.'s work classifying these based on how reducible they are in the emergency department.
How did that classification work out in terms of success rates?
They split them into 3 groups. Group 1 were fractures that could always be reduced, closed in the ED 100% success. Group 2 had about an 80% success rate with closed reduction, but Group 3, these were the ones that were essentially irreducible. 0% success rate in their series.
0%. So if you encounter a group 3 pattern, one you just can't get back in with gentle attempts, what's the algorithm?
This is critical. Do not keep trying forceful closed reductions. You risk causing more damage, potentially to nerves or vessels. The recommendation is clear. Stop trying. Get a CT scan, ideally overnight if possible, to fully understand the block to reduction. Then, book the patient as the first case on the next available trauma list, and very importantly, get the on-call shoulder specialist involved, ASAP. These need surgery.
Okay, so operative management is required. What's the surgical plan look like?
Preoperatively, it's that familiar decision fork, ORF versus replacement, often RTSA, largely based on the patient's age, bone quality, and functional demands. But you have to go into it knowing the AVN risk is extremely high with fracture dislocations.
Especially if those Hertel criteria are met.
Yes, particularly anatomical neck fracture, short metaphyseal extension, medial hinge disruption. That 97% PPV for ischemia is very relevant here. Intraoperatively, it's usually a delta pectoral approach. Again, finding and securing the tuberosities with sutures early is vital. If doing ORIF, the challenge is getting the head reduced out from wherever it's stuck, holding it, and then applying the plate. Definitely using that kickstand screw. If doing a replacement, you remove the shattered head fragment and proceed with the arthroplasty.
And post-op?
Close neurovascular monitoring is paramount, given the injury mechanism and the surgical manipulation needed.
It sounds like a much tougher reduction. What's actually happening biomechanically in a fracture dislocation? Why does it happen?
The thinking is it's usually not one single event where bone and ligaments fail at the exact same time. It's more likely a sequence. The shoulder probably dislocates first, maybe anteriorly. Then, as it tries to reduce, either on its own or with manipulation, the humeral head gets caught or impacted, often by a large Hill-Sachs lesion engaging on the glenoid rim.
Ah, so the dislocation happens, then the fracture occurs during the reduction attempt.
Exactly. That forceful impaction during the blocked reduction, combined with often poor bone quality, causes the humeral head or neck to fracture while the head is still out of the socket, or as it's trying to get back in.
That makes sense, a dislocation leading to a fracture during reduction.
Yeah, it explains why they're often irreducible closed. The fractured fragments are physically blocking the path back into the joint.
Okay, let's try and pull this all together. For residents studying for exams, what are the absolute key takeaways from this deep dive based on the note?
Right. First, know your anatomy blood supply, nerves. Second, master Neer's classification, especially that strict definition of a part. Third, understand Hertel's criteria for AVN risk. But critically, remember that ischemia doesn't always mean collapse, thanks to studies like Bastion's.
And for management.
Management is highly individualized. You have to weigh patient factors, age, function, against injury factors, comminution AVN risk.
Mhm.
Evidence like the Prophet trial is crucial, showing non-op is often equivalent for many elderly displaced fractures. ORAF with good technique, including that kickstand screw, is key for younger patients. And replacement, increasingly RTSA, is often preferred for complex elderly fractures where tuberosity healing is doubtful.
And fracture dislocations.
Recognize them as a separate entity. Use Way's classification in the ED. If it's irreducible, group 3, don't force it, get a CT, get the specialist involved, plan for surgery, understanding the high AVN risk.
So as you study, really try to apply this framework, look at case examples, classify them, assess the risks, consider the patient, and then justify your management plan using the evidence we've talked about.
Exactly. Think through the rationale for each step.
And maybe a final thought to chew on. Studies like PROFER really challenge us, don't they? If non-operative care works just as well as surgery for many of these displaced fractures, what does that really tell us about the injury itself? Maybe the factors we think are most important for surgical decision-making aren't the whole story.
It's a great point. It forces us to question which factors truly drive the outcome. Is it the precise reduction? Is it biology? Is it rehabilitation? Perhaps our current classifications don't capture everything that matters for healing and function. It definitely warrants ongoing thought and research.
Absolutely. Well, this has been a fantastic deep dive into proximal humerus fractures, all based on the Ortho Made Simple notes available at mokyingren.sg.